start going live.
Okay, that's fine. You saw that out between yourself and Dr. Nevondo.
Yes, everything is fine now.
Okay, that's great. Okay, till then.
Sharp.
Oh no.
Doc, you can stop sharing, and then I'm gonna play a video first, and then you will share after that. Immediately after the video. Thanks.
We are celebrating 21 years, and what better way to do it than to make sure that we go to communities that support us, we make sure that we give them educational information around their health. We are here as the clinic's family to do health screenings for the community around here. This is part of what we do in playing our part as a healthcare provider, ensuring that people understand what diseases they have, they understand that they have to manage the diseases, prevent them before things get worse. It's part of our 21st birthday anniversary for our clinic, which is based in Sebokeng, the Naledi Nkanyezi Hospital.
I'm not happy. So it's freaking affair. I'm not
Good evening, colleagues. Thank you very much for joining us once more this evening on a Thursday as we continue connecting with you and contacting you on this weekly webinars. It's the flu season has started, and we are all beginning to get the snuffles, and we need to look after ourselves and hope that we all have had the flu vaccine. I know that sometimes you do get it, but you still get the flu, but at least it mitigates against severity. And this evening, once more, we get one of our speakers. It's a welcome back to a dear friend and colleague, Dr. Nevondo, Lindelani Nevondo, who's part of Clinic's family, and he's back with us again this evening. And we really appreciate that time that he is giving to us. And we want to encourage many other colleagues to do the same thing. Please do avail yourselves to presenting at these webinars. And next month, we are actually looking at young, up-and-coming doctors, not up-and-coming, but I mean just young specialists who are making a mark in the field, and we just want to showcase them. And if you are one of those young specialists, we just want to ask that you avail yourselves, even if you are just someone who's not a specialist, but making an impact in your chosen field. Please do get in touch with me, and let's have you presenting at the webinars. We already have one person who's volunteered to present next month, just on the 15th, the day before June 16. And so we still have open slots for next month. Please do avail yourselves. We want to see young people as we celebrate June 16, which is a youth month. Please do avail yourselves. And so this evening we continue for our webinars. As I've indicated, that it's a pleasure to be with you at all times as we present on these webinars. These webinars are CPD accredited, and we just want to request that you make sure that you do give us your details. And once you've registered here and you've logged in, there's no need to send us your details, because then we've captured the details and you get a certificate, whether you are with the Nursing Council or the HPCSA or the Pharmacy Council or the Allied Health Professionals regulatory body. And so, and also remember that these webinars are recorded live on YouTube, and you can get the access to these presentations immediately after this presentation if you are not logged in on YouTube currently. And so once more, welcome. We look forward to a great evening with Dr. Lindelani Nevondo, who's an orthopedic surgeon currently practicing at Clinics Health Group September Private Hospital and Butselong Empilweni Private Hospital. He's also a member of the South African Orthopaedic Association. And Dr. Nevondo obtained his Bachelor of Medicine and Surgery in 2008 from the University of Pretoria. He then completed a fellowship at the College of Medicine, Orthopedic Surgeons, and also the College of Medicine in 2018. Dr. Nevondo further completed his Master's of Medicine in Orthopedics, MMed from the Swakopmund Health Sciences University in 2019. And we are excited to have him back with us. And this evening, Lindelani will be speaking about robotic surgery in orthopedics. I was teasing him just before that. I'm not only going to talk about, I think it's robotics in orthopedics. So, because I think we didn't change that. He said, no, not only surgery, but just purely robotics in orthopedics. He'll explain that. So it's not only confined to surgery. There are other areas that robotic surgery does. Did I log out?
No, you are still there.
Oh, okay, because I don't see myself. Okay, no, that's fine. So, Doc, please take over and talk to us on this important topic.
Doo-doo-doo.
I've lost my screen. Oh, there you are. There I am. Okay, thanks a lot, Doc. You can talk to us.
Thank you, Dr. Bila. And good evening to everybody who have logged in. As Dr. Bila have introduced me, I am Lindelani Nevondo. I'm an orthopedic surgeon working currently only in clinics or Clinics Hospital, the ones in Gauteng. So today me and Dr. Khadev and Dr. Mailane, we just decided to bring you a topic that is making fast forward and is becoming very much a topic of every day for most people, which is robotic surgery in orthopedics. This is following robotics in medicine in general. How do I go forward? There we go. So these are the few things that I am going to talk about in this presentation. So I'm just gonna give you a quick introduction on what is arthritis and how do you manage it, and what are the surgical outcome or the surgical expectations that you have when you do surgical management of arthritis. Then we'll talk about the traditional method of doing arthroplasty or knee replacement. And then we'll talk about when you're doing those traditional method, how you do the cuts and the balancing. And then we'll take that and then we'll introduce artificial intelligence, meaning we'll introduce robots. What do they do? and we'll talk about the advantages that the robots brings in this case. And then I'll show some proof of cases that have been done, and then talk about just a few disadvantages that robots bring, and we'll conclude. So it will not be a very long presentation. So when you say the word arthritis, it's the word that comes from arthro and itis, which is inflammation of a joint. And there are a number of arthritis that are out there. You have your osteoarthritis, your rheumatoid arthritis, your gouty arthritis, septic, psoriatic, reactive, and many other. And if you put them in a flow chart, you have a osteoarthritis, inflammatory arthritis, and septic arthritis. So your osteoarthritis is when you have degeneration of the cartilage of joint, and you can put it be a primary osteoarthritis or a secondary osteoarthritis. When it's primary, it's usually when the cause is not known, and it's usually the most common one. And then you get a secondary arthritis where there's an injury, usually at a young age, which leads to cartilage damage at a later age. Then you have your inflammatory and your septic arthritis. Your septic arthritis when you have an infection, which affects your joint, and then at the end, it causes damage to your cartilage. And then your inflammatory arthritis is when you have a chronic inflammatory condition of the body that end up leading to joint cartilage destruction, like in rheumatoid or in psoriatic arthritis or in crystal-induced arthritis, where you have something like gout or pseudo-gout, which causes cartilage damage leading to arthritis. So when you're a patient with arthritis, the treatment of it, it's a long treatment, it's fast. It doesn't just start with arthroplasty. You have to start with basic treatment like your weight loss. You have to give the patient information. You have to do exercise programs. That's to prevent the progression of the disease. And when the disease reaches a stage where it's painful, you start patients with pain medication, which can start from simple things like paracetamol, and then you can add some NSAIDs, and then going down, you can add some opioids like your tramadol. And if still you have a problem, you can go to intra-articular hyaluronic injections and intra-articular corticosteroids, which is controversial, but it's something that is out there. But ultimately, altogether, when everything has failed, you're going to end up having to replace a joint. Whether you do it total or you do it unicompartmental, it'll depend on the affected compartment on the knee. So now, when you have done a joint replacement, the management, just summarizing it on this one, is everything I was saying. You have your surgical and your non-surgical, you have non-pharmaceutical and your pharmaceutical. And in the end, you're going to replace the joint, be it a uni or a total. And this is just a picture showing the progression of arthritis, where you get the first picture there, which shows just some arthritis with some cartilage damage and some synovitis. The middle picture showing quite severe synovitis, and you can see bone exposed with cartilage loss in some areas. And then the treatment of that was actually a joint replacement that was done. As you can see the femoral component, you can see the poly and the tibia tray. So once you have done a arthroplasty, you've treated the person surgically. Question is, what are the outcomes of surgical treatment? And there are a few studies that are found, and I just took two out. And in these two studies, you can see the dissatisfaction rate in arthroplasty in patients who have been done knee arthroplasties between 15 and 25% of patients that are done. And in patients who have been done knee replacement, you find around 7% that are not happy. Now, these numbers are not little, because if for every 100 patients that you operate, one will be complaining. And when patients complain, they will come forever, and those are the patients that you remember. It's not a good thing. So there are multiple factors. One of the studies was showing that things that causes these patients not to be happy is things like the expectations that the patient have. the pain management that you give intra and outside the operation or before. The age of the patient, the younger the patient, usually the worse the outcome. The sex of the patients, with females more than males, the comorbidities that the patient have, the length of hospital stay, and there are many other causes, but these are the main ones that causes this certificate, that word. Next page. Okay, so the other thing that causes patient not to be satisfied with their knees is when the operation is done and the knee is unbalanced. So when the patient walks, they are unstable, or they have stiffness, or they have loosening. That usually is the main reason, surgical-wise, that causes the patient not to be happy. Like you can see in this study by Lucy Walker and her colleagues. So in just zooming into knee replacement, you got 75 patients that are happy, but you have that 25% of patients that are unhappy. Those are the patients that will come back to your room week after week. And today you give this, tomorrow you do that, but they are never really gonna be happy because there's a problem with the operation itself, or there's a problem with how the operation was done. Even though all of us want to have the 75% of patients that are happy, we pretty much end up with the unhappy patients. And we have to address this unhappy patient. And one way to address the unhappy patient is to go back to the operation and say, okay, once the patients are done, before the patients are done, what can be done to make the operation perfect? And one of the things that we have to do is to balance the knee. A balanced and a stable knee is what the patient is totally looking for, and the patient can use that knee for longer, and it reduces wear and tear of the implants that are inserted, and the patient will have good proprioception. And in the traditional way, which I still myself am more a traditional arthroplasty surgeon, when you're doing arthroplasty, the aim of it is to get the knee that is balanced in sagittal plane, meaning the patient is able to flex and extend. So you have to balance your flexion and your extension gap to at least what the patient had before the operation. If you can improve it, even better. Most of the time you end up losing about 5 degrees because of the operation. Then you also have your medial and your medial and collateral compartments, where you have your lateral collateral and medial collateral ligaments, which you need to balance. And you also have your axial plane, which talks about your knee from the femoral head to the ankle, where you check if it's in valgus or in varus. And you also check the joint line, how it is. And this is more or less what I was talking about. This is the long picture showing the long axis of the lower limb, where you can see the knee can either be neutral, or it can be in valgus, or it can be in varus. So before you operate the patient, you have to take this into consideration, and you have to also check the contralateral leg, see if there's anything. And it also talks about the cuts that you're going to do on the patient. Whether you're going to do just on the tibia, you're going to cut everybody into 3 degrees of valgus, or you're going to make everybody straight. It has a lot to do with it. It affects your operation. So when you're doing the operation, in this table, which was a nightmare as a student, where you are checking your gaps, whether it's tight in flexion, it's tight in extension, tight, and then you get to work around it to see what can you change, what can you do to actually end up with a balanced knee. So when you think of all those 3 planes and you have to balance them in your head, and there's nothing tangible that you can use, it becomes a bit difficult. So just going into the cuts themselves and balancing, when you cut in the knee, like what you can see on the picture there, you use jigs in the traditional method, where the jig is preset to 3, 6, 9 degrees, or whatever you want it to be at. And once you have inserted the jig, you literally gonna cut what you have put there. And you also you reference your knee using in the either internal or external referencing, which can also be affected by the position or the deformities that the patient has, either on the femur or on the tibia. So that can affect your cuts, and it will lead, you may end up with an unbalanced knee, which will lead to the 25% of patients that are complaining. And also the saw, when you're using the saw and the jig, you actually have to put the jig and put it down with some screws so it doesn't move, but that's not guaranteed that it won't move. It might still wiggle a little bit, affecting your cut. And when you're balancing your ligaments, you actually, once you've done it a few times, you feel, is my ligament tight? Is it loose? Do I need to increase the poly size, or do I need to downsize, or do I need to cut the tibia a bit more? So there's quite a lot of user dependence to it. And it's difficult also to pre-plan what you're going to get in these patients. So that makes artificial intelligence something that becomes important. So we come to the era of artificial intelligence. Now, the question is, do we have robots that are sitting there operating the patients with the surgeon sitting somewhere else? No. The answer is no. This is robotic assisted surgery. So just going back to history, in 1896, we know Henry Ford built the first car, which was a 4-horsepower car. And by that time, it was one of the greatest achievements ever. Suddenly, humans can actually sit down and then they can move from one distance to another. Suddenly, you have a machine that has the power of 4 horses. And it was quite a big improvement. And then when you look at that car and you look at the current 3.5 liter, 600 horsepower Ford GT, it's like we've moved from one planet to another planet and we found something else different, because there's so much rapid improvement in technology that even in medicine, we can't stay behind and say, we've been doing arthroplasty the old way, it has worked. But progression is going, artificial intelligence is here. We also have to move on. Just like computers, the first computer that was made was as big as a house, and it has such minimal function that it couldn't be afforded by many countries. And they start improving. You have your computer that was using a stiffy disk and going on to those big keyboards, and you had a CD-ROM and CD-ROM rewritable, and it progresses until your computer can be as big as your hand and still do far better function than the biggest computer. So in terms of computers, the size has been decreasing, but the efficiency and the power has been increasing. When you talk of robots, they also have been, as the computer increase in function and their reliability and their precision, even in medical world, the same thing was happening. Like in 1980, you had the first use of a robotic surgery in brain biopsy, progressing on to urologists using the Da Vinci to do urological operations, where the surgeon doesn't even sit next to the patient. You do it almost totally using robotic arms. And orthopedics couldn't be left behind, where we also started using robotics to do the cuts, which is the one thing that affects us the most. And then companies like Synthes, Zima, and the other companies, they started coming up with the robots or the robotic assisted arthroplasty. The first one being the knee, and now we're talking about the robotic assisted hip replacement, but we won't talk about that one today. So what advantages do these robots bring? One of the best things that they bring is the pre-planning. You are actually able to sit down, do x-rays of a patient, put them in a computer and see what kind of phenotype the patient is. and then plan from there onwards to say, okay, what am I going to do? During the operation itself, you enter the data of the hip, you enter the data of the knee, you enter the data of the ankle, and you're able to know what type of phenotype the patient have intra-op, which makes planning intra-op even easier. You're able to choose the implants that you can use on that patient. You're able to choose the sizes of the implant, and you're also able to enter the balancing parameters where you can tension your ligaments and incorporate that to your operation. So, and with a computer, it's the speed that it does it in is almost like a live operation. And when you finally do the cutting of the bone, it's easier because you do not use a saw, you do not need a jig. You actually, the computer almost cuts to a nearest 1 millimeter. So the planning, like I was saying, you take a long leg x-ray of the patient, hip, knee, and ankle. Then you can measure your MPT angle and your FDF8 angle. This determines the phenotype of the population. There's something called the CPEC surgical goals. This is being introduced mostly by Prof. Belleman from Belgium. So once you have measured your two angles, you can determine whether the patient is in valgus, in varus, in neutral, and then you can plot them into one of those squares, which is basically the phenotypes that you find in most patients. And then you can also go and score them according to their CPEC classification. This data that you find, the LDFA and your MPTA, like 89 and 87, you can literally enter them straight into the, once you have classified the patient into it, there you can enter them straight into the computer or the robot, which in turn tells you what cuts you can do. It won't be 100% the computer deciding. You can still tweak it around a little bit and come up, but it gives you such a good plan. So that's the angles I'm talking about. So those two angles probably are the most important angles that you play around when you're doing the robot. So with your operation, during the operation, now that you have entered the data, you can have live information about the patient, like the hip and the knee. You can check the range of motion that you have. You can check the ligament stability or instability that you have. And you can plan the cuts that you're going to do. And you're going to plan the implant sizes, and you can incorporate the deformities that are there into this. And that helps you make a decision on what implants am I going to use and how much stability am I going to get on this patient. So when you are entering the information, once you have entered the information, you end up with something like this, intra-op. It's a screen that you can touch and you can play around with. But already you can determine the cuts that you're going to make. Like in this patient, you decide tibially, how much am I cutting? Femoral, distally, how much am I cutting? And you can also see the tibia sizes that you have there. You can see this patient was going to get a tibia size of 7. You can, with a thickness of poly of 9. And before the operation, the patient has a flexion range of 143. Then you can also see what is going to be after. And before this patient was operated, the pre-op alignment, the patient was in 5 degrees of varus. Post-op, you can get the patient to 0 degree of varus, which you can still tweak around. Looking at the phenotype of the patient, are you happy with that? Is the patient a varus patient or is it a valgus patient? What is their CPEC classification? So all this information, you get them live while you're doing the operation. And when you've done that, you also go to your implant screen and you take the implants literally, visually, and you put it on the bone that you have mapped on the patient. And you can check, does this fit? Is there an overlap? Is it too big? Is it too small? Is it notching or is it not notching? And this information you're getting while you are there, before you cut the patient, you already know what you're gonna do. Once you are happy with everything that you have done, and you have seen your flexion gap and your extension, when you're happy with everything, then you are ready to cut the patient. Now, in the olden days, when you're cutting the bone itself, you're going to take a saw. You're going to pin down the jig, and then you take a saw and go, which the jig can get loose, the pins can get loose, and it affects your results. With this little device called a burr, it makes life so easy. It's going to bear down to the level where you measured, to the nearest millimeter, really. You hardly make a mistake with this. And there are no pins, there's no jig, so chances of loosening of anything during the operation are not much. And this is one case that we did in Cape Town last week. This is the jig that you can see that you're actually literally holding it like a pencil, and it burrs all the bone away. And then you get a flat, straight surface that you have measured. So it makes life far easier. So what the robot does not do, like this robotic assisted arthroplasty, this machine, they do not substitute the surgeon. So they don't do the operation. All the decisions that are there, the machine will suggest. You can tweak them around, you can change them, you can do what you want, what you're comfortable with. But at least you have a, excuse me, at least you have a basis, you have a reference on what you need to get and what you had before and what you want to get after. So the robot does not do the planning, it just brings the knowledge to you. But it improves your planning, it improves your precision, it reduces the complication. That 25%, you get it down. It improves the patient satisfaction. So this just a picture or a diagram showing some of the robots that are used in doing arthroplasty, in assisting arthroplasty. The one that I'm familiar with is your Corey. Before the Corey for Smith & Nephew, there was Nivea. And then you got your Rosa that Sima is using. And then you got your Marco and from Striker, and you got your files from Dupuis Synthesis. The screen that you use on this, the planning, the pins, all of them are almost similar. The plan still lies with the surgeon. The operation still lies with the surgeon. The decisions are still the surgeons. These things, they just assist you. And they make precise decisions. Just as we come into the end of this is a case where a robotic knee was done. As you can see, the two surgeons there, is the tall one is Dr. Khadebe, and there's also, oh, that's me. And what you can see is the screen on the one side, and you can see the cutting being done. So we have done some robots, and this was the first that we were doing in Naledi Nkanyezi in Vereeniging. And we also have to go and seek for knowledge because you have to learn. So we went last week to a course in robotic arthroplasty. That's the case we were doing there in Cape Town last week. And this is the team from Smith & Nephew that is pushing very well on robotics. And I think they're doing a great job. And as you can see on the corner, there is the prof from Belgium. And you can also see in the background there, Dr. Mailane, who is also doing arthroplasty, and he have done a few robots in SK Mateke. That's still Dr. Mailane. So what are the disadvantages of doing this robotic assisted arthroplasty? Number one, obviously, is the cost, because you can buy the machine itself. I think it's around $400,000, which is a lot of money, but it's a lot of money when you're looking at the money itself. But if you look at what it can get and the results that you get, the less complications that you get, and the happier the patients, you get more patients. So in the long run, it's not the price that's high. There's also the consumables that you have to buy with this. I think they roughly add your price by around 8-9 grand, which some medical aids are really accepting it because the complications are far less. I think this is going to be one of those things that probably no hospital shouldn't have at one stage. And then there's the very steep learning slope when it comes to robotics. The people are talking about 9, some talking about 17 cases that you need to do before you're comfortable with. But by your 4th case, you already know what to play around with, how to play around with this thing. You already see the results, you already see the improvement, and you can, even the comfort and when you're doing the operation itself, it starts improving. So, in conclusion, is this the future? And I think so. And the words that I was finding on this is this robotic is bringing precision. It's bringing anatomical congruence. It's bringing good range of motion, less material in the future. And this computer-aided design, it actually imitates the natural knee. So robotic assisted knee or hip replacement or arthroplasty, it is here to stay. I think we're the ones who need to catch up with it because it is evolving very fast and rapidly. And it adds real benefits to the patient. The thing it will not do, it will not substitute the surgeon. Well, maybe not in the near future. And those are some of the where I got most of the material. Thank you. Wait, am I alone? Oh.
No, you are with me. We are here.
Oh, great.
No. No, we are all here. You seem to be having the same bug I had earlier on, and I couldn't see myself. Yeah, no, we are here. We've got almost 200 people with you logged in here, and I see people are quite excited and happy about the presentation that you've just made, and we at Clinics also quite excited and happy that we had our first robotic surgery at Naledi Kenyezi a few weeks back together with Dr. Mailani. I just wanted to check if Dr. Mailani is logged in, and maybe if he wants to maybe add a few more words after this wonderful presentation. Is he there, or any of your other colleagues who were part of
Mailani?
Are they there?
I don't see them.
Okay, they're quite busy doing another robotic surgery somewhere. Okay, thank you very much. It's exciting to say it's still the future, and I think I like the idea that you're saying that robots don't necessarily replace the human doctor. That you are still in charge of the operation, and it just enhances the planning and the operation. I just want to check. I think I see someone is commenting about the nurses. Well, awesome, glad nurses still have a role. I think last week we also had someone from the nursing fraternity doing a presentation, and they similarly indicate that the nurses are also part of the future in terms of robotics and digital technology in nursing care. What did it take for? I mean, you as the doctors were leading the planning and the training, and what about the nurses? How did it go about, and how long did it take to get nurses involved in this type of surgery?
Dr. Bila, I think doctors are probably going to be replaced before nurses are replaced, because nursing is about the patient in total. Yeah. When you're doing an arthroplasty, to a certain extent, it's wrong, but you end up concentrating on the knee. If the nurse is not there, you're probably going to end up going somewhere very far, which is very wrong. So nurses are going to be there. They will always be there, because even during the operation, if you have an experienced nurse in this robotics also, they will literally be pressing the screen for you and showing you, oh, doctor, your varus is not enough, or so. I think by introducing it, I think the nursing team must not feel anything. They're still as important as they are. And the implants that, the sets that have been used are no different from the sets that were used before. The only thing added is navigation. So nurses will always be important in theater and outside.
Yeah. But the nurses have to go for training. That's what I was asking. Before you can, or is there's no special training for nurses to be, before you start this surgery, this type of robotic surgery?
I think most of the time the nurses are usually taught by the rep who comes most of the time. Like once it's not the learning slope for nurses is it's not steep at all. Like 1 or 2, 3 cases, they probably be comfortable doing the whole thing. There's not much added to on the nursing side in this. I don't think they need to go for any special training at all.
Okay, it's comforting to hear that. And in terms of the time taken to do the surgery, is there any difference in the time factor if when you look at robotic surgery, doing the traditional surgery without a robot? Are there any advantages in terms of time? I might have missed it there, perhaps.
Yeah, I don't think I added it. But yes, there's definitely in the beginning when you're starting with this.
I'm losing you. Is it me or you're fading off the doc? Kamu, is he? I think we're losing Dr. Oh, there you are. Oh, is it load shedding? I see you. Oh, it looks like we are losing you. Yeah, I think there's load shedding at the hospital. Yeah, load shedding is affecting all of us. It even affects our webinar presentations. We'll try and see if we can get Dr. Nevondo back online. If you just give us a few minutes to just check if we are able to reconnect with him. Just a few minutes.
No, he locked out. Now he's back.
Okay, thank you, Doctor. Definitely, we've got load shedding, and Dr. Nevondo will try to log in back. He's got a colleague. We were talking to. We was checking if he's in here. Dr. Mailani. You're one of the experts who worked on robotic surgery. I hope you can be able to take a few of the questions that we have. Dr. Mailani, are you able to unmute yourself? Can we just check if Dr. Mailani is there?
Hi, Doc. Yes, he's in.
Maybe he's a bit having problems to unmute himself. in the meantime, I think the question that we have is what is the percentage drop in dissatisfied patients when using robotic surgery? That's a question that we wanted to, one of the Dr. Reuters wanted, is asking. I don't know if Dr. Malani is logged in, that we can deal with this question, or any of the other colleagues who were involved in robotic surgery at one of the hospitals, Dr. Hadebe, if you're there. Or maybe any of the orthopedic surgeons. I mean, what is your feeling, those who are not yet doing robotic surgery? Maybe if you talk to your colleagues, what are the concerns that you have, or what are the experiences, or what are you hearing from the colleagues that are involved in robotic surgery, in orthopedics, or just maybe robotic surgery in general? Last year we had a full month dealing with artificial intelligence and machine learning, and it was quite an exciting time that we had from different speakers, and even the people who are working in IE, I mean in ITU at the university at UJ, talking about the future of medicine and how this type of intervention and innovation is going to be something of the future, and that medical training is going to be one of the things that we are looking at. I'm going to put Professor Makunyana on the spot as one of the academics, and also she's an ophthalmologist, and just to indicate to us in ophthalmology, are we seeing any advances in terms of using robotics? I mean, you're more using machines in your practice. Prof, are you able to comment?
Good afternoon or good evening, colleagues. Thank you, Dr.
It's
Bila.
evening.
Yes, evening. Yeah. Yes, actually, the technology, there is an improvement. There is a lot of improvement in the technology. We are now, for instance, just our phaco-emulsification that we do for cataract surgery. We are now using small incisions. And there is really just a lot of advancement actually taking place. It's going to get to a point where we really just cut the eye with using laser and not really making incisions ourselves, cutting the cornea for corneal transplants, and doing capsulotomies on the lenses of the eye using the laser. So we use a lot of laser technology in ophthalmology. Thank you very much.
Yeah, I thought so that that's a field that could be leading in this advancement in technology that's available. And nowadays, I think there are lots of patients who are using laser now. In terms of ophthalmology, what is the trend now? Are we seeing more and more patients opting for that, and what are what's the success rate, if any, of patients opting for that type of surgery?
Well, this is obviously very expensive technology to use, and we, in the public sector, where I spend most of my time presently, are not at that advanced stage, of doing surgery on the eye using laser for cataracts. However, in large private institutions such as Pretoria Eye Institute and many others, they do use it a lot. And of course, just like in robotic surgery, all the parameters that one finds with the robots, the precision is out of this world. And of course, the outcomes are improved. So, we do use it, for instance, for refractive surgery. That has been going on for a while now. The outcomes are good, are really outstanding. And The only thing I would like to add there is that, as the medical fraternity, we probably do not need to panic in that, robotics and lasers are not going to, I don't think they will replace the human touch. They will not replace us. However, they will augment and complement our service to our patients. That's my view. Thank you.
Definitely. No, thanks for that input. Yeah, I think it's quite true what you're saying that there should not be panic amongst the colleagues that ultimately robotic surgery is going to be replacing the doctors in general. I think Dr. Thanks for stepping in there, Prof. Kunyane. She's also a member of the risk committee at Clinics Health Group. We're quite excited and happy to have got such people working and making sure that we improve our quality of care for the patients that we see in our hospitals. Dr. Nevondo, you're back online.
Yes, I am.
Yeah, so no, thanks. We're glad to have you back. We moved away from orthopedics, we went into ophthalmology, and Professor Morgan generously stepped in for us in that period. We've got a few more questions. Maybe let me just deal with this one. Thanks for the great presentation, Ms. Joanna Musime. Are medical aids embracing these advancements with ease? What is your take and what's your experience?
I didn't get the question.
No, the question is from one of our group medical relations manager. She just wants to know, are the medical aids embracing robotic surgery interventions with ease? So you don't have any problem with, especially now in the private sector, to claim for these cases.
I'll even speak for both private and public sector. For both private and public sector, like there are some public hospitals that are already running robots.
Okay.
Like a hospital like the one in Tygerberg, they got like 4 types of robots in the hospital, which is a public hospital, and they're doing quite a number of it. So, and their results is going up. In private, the clinics we're not at the forefront of this.
Yes.
We're probably more at the back of it. So the hospitals like Mediclinic and Netcare, they already have robots in their hospitals. So, and the medical aids have accepted, they are compensating for their patients. It's still, I think we'll still have to go through, negotiate with a few medical aid to see if they can allow us, but they are allowing. So they do pay for this most of the time, because they have seen the results and they've seen how precise it can be, and they've seen the less complications.
Okay, so medical aids generally do embrace this.
Say what? Hello?
Yeah. Okay. So the other question, I think maybe just when you mentioned that maybe in clinics but we are also embracing robotics, robots in our pharmacies. I think Dr. S came and said Memorial Hospital, we do have we've introduced robots in terms of dispensing. We've got
yes,
that innovation that started about a year ago. Now the next question from Dr. Red is, what is the percentage drop in dissatisfied patients when you're using robotic surgery?
Yeah, that's a difficult question to answer.
Dr. Nevondo?
Can you hear me? Oh my God. Hello?
No. Yeah, the question is, what is the percentage drop in dissatisfied patients when using robotic surgery? I mean, what are the outcomes? I mean, to the patients?
In percentage, like I was saying, it's a bit difficult to tell right now, because the robotics is still quite a new thing. Usually when you judge something, it's usually a 10-year run on to see how much complications you have reduced and stuff. So it's still a bit early, but for what is worth, most of the people who have done the robots, the ones who are doing a lot of them. They swear by it. I don't have the percentage to it. The one personal doctor who said it was he has dropped his complication rate initially at the beginning by 10%, and now he's talking like his percentage is at 5%. But there's nothing that I've seen published on that. I think for a research to be properly done, it will take a few more years to see more complications or less.
Okay. Sure. Yeah, I'm better to hear. Another question is robotic surgery used for total hip replacement? And if so, is it any superior to conventionally total hip replacement? If you said superior, is it available in South Africa? I think that's what you mentioned.
Yes, the answer is yes. Robot.
Do you want to comment on this?
Can you hear me? Hello?
Yeah, go ahead.
Yeah, yes. Companies are starting to bring robots to the hip for hip arthroplasty. And because of the precision that you can get with a robot, there's no more guesswork. You're not worried about your gap balance. You can actually feed that into a machine and you get the results that you desire. It's superior to traditional operation. Still, there's a big a steep learning curve to it, but it is now being done.
Okay, that's fine. Yeah, sure. But there's also concern that it might be an expensive procedure. Is that the case, that the robotic surgery is quite expensive at the moment?
That is the case, definitely, because you're bringing a new thing, a new machine, and there's some consumable to it. In the beginning, it is expensive, more especially if you are hiring the machine, and if you, like in hospitals where the arthroplasty is not done as regular, the costs seem to be higher. But in the long run, for the patients, for the medical aid, even for the hospital, you have less complications, which leads to saving more money. So you will have a huge initial cost, and then in the end, you can make back the money and even more.
Yeah, that's great. But in terms of patient selection, do you have to choose your patients carefully, or is it that any patient who comes to you would offer robotic surgery? Maybe take us through the process of patient selection.
Well, when you are sorry.
Yeah, just go ahead. Yeah. Dr. Mailani wants to respond. Dr. Mailani?
Yes, hi. Sorry to interrupt the question. I'm just going back to the previous question about the cost burden with regards to robotic surgery. As it stands now, what happens is that the companies are actually just charging for the consumables, and what they do is that with the robots that stay at the hospitals, the non-portable ones like your Mako and the Rosa, those are the ones that they have like a lease agreement. So they'll say to the hospital, okay, we've got a high volume surgeon who does an X number of operations, so then it will actually pay itself off as time goes on. So they'll lease it, and then they'll only charge for the consumables. So with the Cori, right now they're actually just charging for the consumables. So the pins that you put into the patient, and also the probes that are there on the patient, because those get soiled and those can't be reused. And then they kind of like rent it out. So the cost is not that much more than your conventional arthroplasty surgery.
No.
Okay.
Yep.
Okay, thanks for that response. So you've answered the question that was raised a little bit earlier.
Yep.
Okay, and maybe either you or Dr. Nevondo can answer this question in terms of patient selection.
In terms of patient selection,
Dr. Nevondo, you're about to respond to that question.
Yes. In terms of patient selection, In the beginning, like when you're starting,
Yeah, sure. Go ahead.
When you're starting to do robotic surgery, you usually choose patients that are easy to do, like that has less complications, and those can call it practice. But when you become advanced in robotics, actually people are choosing to do robotics in complicated cases because you're able to incorporate the deformity and everything into a robot and do it. So for a surgeon who does it regularly, it's for every patient. There's no really much selection.
Okay. All right. Dr. Brett Thompson, your hand is up. Go ahead, please.
Thanks, Ray. Really appreciate it. It's very interesting, that point that Dr. Mailani shared about some of the companies waiving the cost of the actual robotic device. And I do believe that is going to go a long way in sort of, from a funding perspective, to alleviate that cost burden. For the bigger schemes, some of them can manage to cover and meet the cost. But for your smaller schemes, this does sometimes become a challenge, especially where you have a population that is going to be utilizing arthroplasty quite more than other younger age groups. So I think that's a very interesting point. Yeah. And it'll be nice to know how long is this bona fide offer going to be on the table. Thanks, Ray.
Okay, thanks, Clyde. Okay, Dr. Nevondo, you want to comment on the last comment about this nice cozy relationship between the companies and the surgeons? How long is it going to last? Do you have an idea?
I believe the companies are giving us a bone so we can bite, and when we have bitten, they will take it away. It will last once we have more patients and more medical aids acknowledges it, then that's probably when we're going to have to take the cost over. I think probably 2 or 3 years might be the time frame.
Yeah, I think that's the time when Johanna Musime will have to get involved and help us with the medical aids. And then, now that you know what's happening, and I'm sure that some of the colleagues who may from the medical aid industry are here, they will be able to understand the challenges and step in and know that this is an innovation for the future, and we need to minimize costs. And I think when NHI is coming also, it's something that we should consider. There's a question, Kalulis is quite your fan. They say that, you are one of the best doctors to work with at Naledi, Dr. Nevondo. Yeah, Clive says it's count and stick in this relationship. What are the chances of the robot malfunctioning while operating, and will this compromise your operation?
Well, Bilal, I think the question is from Bilal. The chances of robot malfunctioning,
that's it.
For Bilal, is the same as the chance of a CM malfunctioning during an operation. And any machine can malfunction. That's why when you do robotic surgery, you don't start with robotic surgery. You need to know how to do conventional or traditional arthroplasty. So when it crashes, then you take over as the surgeon, or you take over the planning and you continue the operation like you would have done if there was no robot. So the chances of crashing are there. There's many ways to mitigate around it, but it still exists. It's the onus of the surgeon to know how to do a normal operation. Like in med school, they haven't started teaching people robot first. They teach you how to do a normal knee, so you can bail yourself out should ESCOM take their power or something like that happen.
You've triggered a new question for Dr. Mashir, one of our regulars here. Now that we've spoken about the robot malfunctioning and then there's human intervention. Now you want to know, I think this is a practical question. These instances where human intervention is required in arthroplasty because of failure. Have you had any instances? I mean, at least this one we've had arthroplasty for some years now. There is quite I think experience that we can refer to.
I think the first thing about this is robots are not doing the operation. The surgeon is not a bystander in the operation. You doing the operation, the robot is assisting you. Like it's not an instant where the robot fails and now the surgeon has to be woken up. Now the robot, no, the surgeon is there. For instance, number one, it's our dear ESCOM. If you get power shortage in theater, depending on where you are, some theaters don't have proper backup. Or if your backup also fails, then you're gonna have the machine switching off. In that instant, you don't have all the planning that you've done. You can't do the intra-op planning, you can't do the post-planning. So you become the surgeon like a normal surgeon. That's where you can take over. The robots that you are using, they are literally machine which uses algorithm. At some stage, any algorithm can have a glitch, it can have a failure. That's when you take over. Even when you're doing your planning, you as a surgeon, there are instances where you override the surgeon. If it's saying 2 degrees valgus, but you want 5 degrees valgus, you can override the machine. So the machine is not a definite, it will do everything. No, you take over. So in instances where the machine fails.
The question is also, okay. Yeah, but in terms of arthroplasty, I think Dr. Mashur wants to know, when you're doing arthroplasty, are there instances where human intervention is required because of failure? I don't know, lo and behold, you don't have the full equipment or something.
I don't know if I get the question right. I was saying human intervention need to be there all the time. The robot is the assistant, the human is the surgeon.
Okay. All right. I think we've covered most of the questions. Quite an exciting topic, and I'm sure we will do more discussions. We've had a discussion on robotic surgery in urology in the past, and I'm sure we'll hear more. I think we've had AI in myocardial infarction and predicting failure or predicting instances where patients will have myocardial infarction. I'm sure we'll revisit this topic sometime in the future. But I just want to thank you, Dr. Nevondo, and I think also Dr. Malani for joining in for the great work that you're doing within Clinics Health Group, and we trust that robotic surgery will not only be a matter for the one hospital, but it will be the other hospitals joining in. And thank you for taking your time to prepare for this presentation and being a part of this body of knowledge that we're increasing, and that we're working together with you within Clinics Health Group every weekend. We appreciate the time that you've taken. And as I said at the beginning, that we're encouraging even the other specialists or colleagues. I've just been sending out messages to those that I know who are quite much younger and in the field and doing great work in our hospitals, just to avail themselves to present as we celebrate Youth Month. Already we've got a few slots filled in, but 1 or 2 slots are still available. So we just want to encourage you. Please do contact me if you want to do a presentation next month. And I just want to thank all of you colleagues who've been joining us week in and week out at this webinar since we started. Without your support, we won't be able to do this webinars, and we appreciate the time you take to engage also with the speakers who are coming in every week. But also to thank Gamo from Clinics, who's working with us together with Sistoko for marketing to make sure that we do have speakers ready to present every week. And just to also our management, EXCO in Clinics. So Dr. Kidoshi has joined in this evening. We didn't give him time to say a few words, but we'll do so next week or so. And thank you, colleagues, and have a good evening.
Thank you, Dr. Bila, and everybody.
Thank you for me.